Hello everyone, this is Dr. Morphine. Today I am going to teach you the miscellaneous cases in SimMan that we will get in PLAB2. Alright, so most important case is morphine toxicity. Patient will present with sleepiness. Alright, and a prompt will be telling you that patient has taken some pills because of back pain. So doctors, only case remember in PLAB in SimMan where respiratory rate would be low. It will be not more than 7 or 8. Alright, then you will examine the pupils and pupil will be pinpoint. So direct clue, taken morphine, respiratory rate less than 7, around 7 or 8, less than 10, pinpoint pupil, this is confirmed morphine toxicity. You will be giving the log zone 0.4 milligram. And reassess the patient after 2 to 3 minutes, not feeling better, then 0.8 milligram. Still not feeling better, again 0.8 and then 2 milligram. Most of the times in examiner will improve the patient when you will be giving the second dose. Alright, this is one of the most important case. Best thing about this case is you just need to give one medication, that is naloxone, and it is like direct clue, respiratory rate will be low, pinpoint pupils, you will get to know this is morphine toxicity. Alright, so after morphine toxicity, next case is hypoglycemia, one of the most common cases. These days it is coming as conscious patient even. So causes could be two: diabetic patient, taken insulin, skipped meal, now presenting to hospital, alright, with unconsciousness, with dizziness, with sweating, tachycardia, not feeling better, or alcoholic, found outside the pub, and ambulance brought him here. So doctors, when in D part, when you will check the blood sugar levels would be low, would be around 1.8 or 2.1 or 2.2 millimole. So after checking the blood glucose levels, you will say, I can see that my patient blood sugar levels are lower side. I am going to give my patient dextrose 20% 75 ml. So doctors, one confusion people have, if it is 75 or 100, both approaches are fine, because this is a range 75 ml to 100 ml. 20% both you can use, either 75 or 100, both are fine. Some guidelines say 100, some guidelines say 75, both are fine, don't worry about this thing. Doctor, one important thing regarding this case is that here, if patient is alcoholic, you must need to give patient thiamine, 2 ampules of thiamine. That is so important in this case, doctors. Alright? You must need to give thiamine to the patient. So, either diabetic, just give dextrose, and if it's alcoholic, first you need to give 2 ampules of thiamine. You will verbalize, as my patient is alcoholic, I would like to give my patient 2 ampules of thiamine, alright, and dextrose 75 ml, 20%, alright. So this is how to approach the hypoglycemia case. Next case, doctors, ALI, acute limb ischemia. Patient will present with leg pain, but remember, even if it's leg pain, still you need to complete ABCDE approach, alright. So leg pain case, you will just ask 2 to 3 questions regarding Socrates. Important question is pain score. Then when we will be examining the leg in E part, we will find it will be pale or bluish, it will be cold, reduced sensations, not able to move the leg properly. And when you will check the pulse, there will be no pulse. The dorsal aspirates will not be there in the affected leg. So doctors, if score is 8 or more than 8, you are going to give morphine. And after checking the pulse, when there is no pulse, you need to give oxygen 100%. Remember, oxygen 100%. Saturation will be fine, but you are going to give 100% oxygen. Examiner might interrupt you when you will say, I can see that there is no pulse, I am going to give my patient 100% oxygen. Examiner will say, why you are giving oxygen? Saturation is fine. You will say, to prevent tissue damage, I need to give my patient oxygen 100%. And last thing is heparin. 5000 units IV heparin you also need to give. So in acute limb ischemia case, 3 medications: morphine, oxygen and heparin. Morphine in C part, oxygen and heparin in E part after checking the pulse. Okay doctors, so next case is pulmonary embolism. Patient will present with chest pain and shortness of breath. Causes could be long flight. Patient will give you history. When you will ask if there anything specific happened, he will say, doctor, I just returned from Australia, just took a long flight. Either he had some kind of pelvic surgery or she might be taking COCPs. So chest pain SOB most likely it will be pulmonary embolism. And in C part we will verbalize the levels of D-dimers. That is important in this case. D-dimer you need to check in this case. If patient is unstable, doctor, like BP is reduced, their like vitals are not stable, patient is unconscious, so then you need to give LT place 100 milligram. All right. And if patient is stable, you simply need to give enoxaparin 1 milligram per kg. If patient is 60 kg, then you need to give 60 milligram. That will be subcut. All right. Patient, and most of the time patient will be stable. You may definitely having chest pain, little bit of chest pain, but patient would be stable. Last thing is CTPA. In this case, this is so important. While explaining to the patient what you are suspecting, you need to tell him that I am going to that specialist will come and see you and need to do a CTPA. Okay, scan. And in this case, examiner might hand you the findings of increased D dimers as well. Chest pain, SOB, D dimers, examiner might hand you the findings of increased D dimers. Patient is stable most of the time. You need to give enoxaparin subcut 1 milligram per kg, and then specialist will do CTPA. Alright, so doctors, about acute limb ischemia, one thing I want to mention here, important tests in this case is heart attack markers. Alright, you need to mention, and then D dimer and clotting profile, because there will be clot, so we need to check the clotting profile. And at the end you will say that you will be doing ultrasound Doppler of the leg and ABPI, and vascular surgeon will assess and might need surgery. Alright, this is important for acute limb ischemia. So morphine, oxygen, heparin, and then ultrasound Doppler, ABPI. Then vascular surgeon will see the patient and might need surgery to remove the clot. That is called embolectomy. Okay, we have done with the pulmonary embolism. Then we have sepsis. Doctors, remember, most of the time high grade fever in SimMan case, most likely it would be sepsis. Alright, this is a tip, it would be sepsis most likely. So doctors, sepsis could be because of community acquired pneumonia or urosepsis. If it's community acquired pneumonia, patient will give you history of fever and cough from last few days, and now he presented with confusion and not feeling well. And you will be able to hear crackles. Alright, unilaterally crackle you will be able to hear in sepsis case. In urosepsis, probably saying patient has some problem with urination. He was admitted in the hospital. Hospital has started him on some medications, but now he's having confusion. So most likely there will be sepsis case, either pneumonia or urosepsis. But in urosepsis case there will be no crackles. Alright. So doctors, remember the sepsis protocol, sepsis 6 protocol. Give 3, take 3. What is give 3? Saturation will be low. You will be giving oxygen via NRB 100%, 15 liter per minute. BP would be low. You will be giving fluids. That will be ringer lactate. Alright. And you will be giving antibiotics. Right. After checking that there is fever, you will give antibiotics according to hospital protocol. Take 3, you will be checking level of lactate, blood culture, and remember, third thing is urine output monitoring. You will be putting the catheter and monitoring the urine output, not urine culture. Urine culture is not a part of sepsis 6, but definitely you will send the urine for culture, but urine output is a part of sepsis 6. So oxygen, fluids, antibiotics, give 3, take the lactate, blood culture, and urine output. Alright, so after that, doctors, now I am moving towards the dizziness cases. Alright, there are 2 dizziness cases, doctors. One is AFib and one is SVT. Not most common, but might come in exam. So patient will present with dizziness most of the time. That patient will be stable, so you need to take a bit long history, like about for 2 minutes. When it started, how long the episode lasts. You need to rule out other causes like thyroid, like stress, caffeine, diabetes, these kind of things you need to rule out in this case. And when you will order ECG on monitor, you will see irregular rhythm. So you will be giving patient metoprolol 2.5 mg IV. And if he is able to take orally, you can give this orally as well. That would be then dose would be 25 mg. All right. Then if patient is asthmatic, you will be giving calcium channel blocker. That could be verapamil 5 mg. Then doctors, because this patient will be most likely stable, then while explaining to the patient what you are suspecting, you will let him know that we will be checking CHARS score, Has-Blood score, alright, to see the risk of bleeding and stroke, and then we'll be starting you on some blood thinners. Alright, and also explain him that cardiologist will be doing echocardiography and 24-hour Holter monitoring as well. Simple case, dizziness case, metoprolol, beta blocker, asthmatic, calcium channel blocker, Chadwick score, Hasselblad score, and after the checking the risk of bleeding and stroke, start him on anticoagulants. The next case is SVT. Alright, SVT. Rhythm would be normal but narrow complex. QR. Alright. So, first of all, you will explain that after looking at the ECG in C part, we will explain for the Valsalva maneuver. Alright. And then, if patient gonna improve on Valsalva maneuver, doctor he will improve within seconds. Alright, remember, in C part after looking at the ECG, you will see, I can see that the patient ECG is not normal, he is having some problem with the rhythm, I am going to start the patient, I would like to do Valsalva maneuver, patient will improve within seconds, ECG will be fine. If it is not improving, then you need to give adenosine, 6 mg. Then after 1 minute, 12 mg. Still not feeling better, after 1 minute, 18 mg. Most likely patient will improve on second dose. First or second patient will be improved. If he is asthmatic, then again you need to give calcium channel blocker, that could be deltazine. Alright, dose is 0.25 mg per kg. So this is all from the dizziness. I have also discussed morphine toxicity, hypoglycemia, acute limb ischemia, pulmonary embolism, and this sepsis as well. Alright doctors, thank you so much. This is all.